introduction, and thank you all. As Barak has mentioned, this is a really exciting time for us. Training days, we know, will be virtual moving forward because of COVID. And because of the Cardio Webinar platform, we've now seen a lot of webinars being delivered for trainees throughout the country. And for me, the vision, what better would it be if training days were accessible not just locally within Deanery, but could be accessible to all trainees throughout the country. And I think the virtual platform allows that to happen. So for this session, I'm going to talk about AFib ablation, what the general cardiologists need to know. So I can give you a couple of promises. There won't be any electrograms. There won't be any squiggly lines. It'll all be something hopefully very tangible for you to take away in your practice to decide when you think the patient in front of you with atrial fibrillation should be seen by an electrophysiologist to discuss catheter ablation. So the objectives will be, what is AFib ablation? Who should we consider? And importantly, not consider for ablation. One question that I think the electrophysiology community gets kind of mocked about quite a lot by the general cardiologists, the interventionists, is why are there so many recurrences? Can I explain some of the reasons why this happens? I'm going to touch on some of the important complications that I think we all need to know about. What I'm not going to talk about is epidemiology, classifications, the symptoms, medical therapy, anticoagulation, or surgical AF ablation. Now, specifically about medical therapy, we will actually have a later webinar run by one of my colleague consultants at the Heart and Chest, Dr. Mark Hall, which will be titled The Non-Ablative Management of Atrial Fibrillation. And that should be quite an exciting one. And if you want to hear more about atrial fibrillation, some of the topics above, there's a super webinar, which was run by Dr. Dan Rain from the East of England, which is on the BJCA video gallery, which is titled AFib Ablation, an Update. So what is AFib ablation and who should we consider this for? So let's just take Mr. Smith. So he's 65 and he's had troublesome palpitations for about 1 year. He's had one admission to hospital with atrial fibrillation and a fast ventricular response. He's got a CHADS-2 VAS score of 2, and that's based on his age and high blood pressure. And in primary care, he started on anticoagulant rivaroxaban. So that patient, with only that data so far, is referred to an EP clinic for consideration of catheter ablation. So let's just talk a bit about what is AF ablation. Well, atrial fibrillation ablation is a procedure which occurs within the left atrium. For electrophysiologists, the left atrium is something we are very, very familiar with. And this is an anatomical image of the left atrium. And the things to be mindful for are these structures here, known as the pulmonary veins. There are 4 pulmonary veins, the right upper pulmonary vein, the right inferior pulmonary vein, the left upper pulmonary vein, and the left inferior pulmonary vein. And the structure in front of the left upper pulmonary vein is the left atrial appendage. Now, for the EP doctor, this chamber is something we are very, very familiar with, because the belief is that atrial fibrillation occurs because there are signals within these pulmonary veins, ectopic signals within the pulmonary veins, which escape through the pulmonary veins into the body of the atrium and trigger atrial fibrillation. So just to say that again, the understanding, the belief is that signals, ectopics, triggers from the pulmonary veins, they escape into the body of the left atrium and trigger atrial fibrillation. So the objective of atrial fibrillation ablation is to electrically disconnect these pulmonary veins from the body of the atrium. And there are 2 approaches to doing it. The first approach is using radio frequency energy. And the term you may or may not have heard about that we use quite colloquially is WACA, which is a wide area circumferential ablation. That's what a WACA is. And the way this is done is with a ablation catheter, which looks a little bit like this structure over here. And here you can see that structure within the left atrium on a fluoroscopic image. And what it does is it delivers a series of point-by-point ablation around the pulmonary veins in order to electrically disconnect these veins from the body of the atrium. In order to prove that we've done it effectively, we have a second catheter, which is known as a lasso catheter by some commercial companies, which sits in the pulmonary veins to prove whether or not we've achieved that electrical disconnection. That is all you need to know as a general cardiologist about the practicalities of radiofrequency AF ablation. There is a second type of AF ablation, which is delivered by the cryoballoon, which we call cryoablation. So once again, here we have our anatomy. Now, rather than delivering point-by-point ablation, what we can do instead is pass a balloon into the body of the left atrium, position the balloon at the junction between these veins and the body of the atrium, inflate the balloon, and deliver liquid nitrous oxide in order to freeze the pulmonary veins and disconnect the pulmonary veins from the body of the atrium. So here it is under fluoroscopy. This outline over here, you can see, is the balloon, which is sitting wedged in at that os. We can prove that we've occluded the vein by putting in some contrast into it. And then we confirm that we've lost that electrical signal by putting in an electrical catheter in to confirm that that vein is electrically disconnected. So that is it. That is all I think you need to know about the practicalities of atrial fibrillation ablation. There are two approaches, radiofrequency and cryoballoon. One is a heating approach, one is a cooling approach. Now, AF in the last 2 years has been generated some big randomized controlled trials. And there's been a lot of them published in the highest impact factor journals. So if you're dealing with atrial fibrillation, it generates big data because AF is common and there's a lot of money invested in its treatment. So let's go back to our patient, Mr. Smith. All we know is he's got troublesome symptomatic atrial fibrillation. You know he's on anticoagulation and he's tried a drug and he's been sent to an EP. You're faced in front of him and you need to decide, do I send him to an EP doctor, consider ablation? Well, there is no doubt that pulmonary vein isolation is a proven treatment for atrial fibrillation. There are loads of studies on it. The reason I picked out this particular study called Cabana is that this is, without question, the largest ever ablation trial. So if you can imagine, this was a randomized controlled trial involving over 2,000 patients, where patients were randomized to either medical therapy or ablation. So that's a hard trial to do. And this trial was powered to try to determine whether or not catheter ablation would reduce mortality, stroke, bleeding, and cardiac arrest. But I want to put that endpoint to the side because from our perspective, with Mr. Smith in front of us, we're not sending him to an electrophysiologist to have ablation, to make him live longer, to protect him from stroke, bleeding, cardiac arrest. No, we're sending him to an electrophysiologist because we want to help his symptoms. So that is the endpoint that me and yourselves should be thinking about. How effective is AF ablation in managing this chap's symptoms? Well, there was a secondary endpoint in the study, but you can see how significant that was. There was a statistically significant freedom from recurrence of atrial fibrillation in the cohort of patients who underwent catheter ablation compared to drug therapy. And this was measured with a very, very stringent endpoint, which was just recurrence defined by AF over 30 seconds only. Now, the problem with this sort of recurrence is it's very subjective. Your patient has to say, oh, I've got symptoms, or you have to do random Holter monitors and you can then capture, hopefully, an AF recurrence. But in all the other days, you may or may not, you may miss it. But anyway, the point about this trial, and the only reason I'm picking up on this trial, is that this provided us robust data to say that AF ablation works in helping patient symptoms. Okay, so Mr. Smith, maybe we should refer him. Have you got any more data? Well, I love this study because this study, unlike that prior study and unlike all the studies we've seen, asked a similar question, but rather than following patients up with Holter monitors or symptoms, every single patient got a loop recorder put in before they were included in the study. Now that's huge. So just this was in this study, you had 350 patients. These were only paroxysmal patients. And they were recruited in the study, and the actual bits of the study are not so important for yourselves because they were looking at the differences between radiofrequency and cryoballoon, but forget that bit. Ultimately, these are a cohort of patients who all had ablation. And what they did is, around 3 months before they had their ablation, they all got a loop recorder put in. Now that offers you an objective measure of AF burden. And that all of these chaps with their loop recorder in were all on medications. Now, after they had their ablation, they all had to stop their drugs. They were followed up for 12 months. And in this, you can see these colored bars represent the burden of atrial fibrillation before ablation. And it's so small, you can barely see the line that after ablation, the burden of atrial fibrillation was minimal. So if you actually give it some numbers, before ablation, these patients on average had about an hour of AF every 2 to 3 days. After ablation, off drugs, that's massive, off drugs, there was a 99% reduction in the AF burden. Now, for me, as someone who does AF ablation quite routinely, this is really great data to to encourage you and inspire you that what you're doing is of clinical value. But is it always pulmonary vein ectopy that's triggering patients' atrial fibrillation? We must be mindful that there are a number of other associated conditions. And in this little chart, we discuss a few of them: obesity, sleep apnea, alcohol, diabetes, smoking, blood pressure, coronary disease, and thyroid dysfunction. And we need to be mindful that these can also be responsible for triggering fibrillation. Now, alcohol. I find this picture great because it really illustrates a key point. Here you see, on the left, you see, 1 second, guys. Okay, 1 second. Jen. He wanted to be a star. Here you see 3D electroanatomical maps of patients who had different, who all underwent AF ablation. And what you see in this particular picture are 3D maps of the left atrium. And I think this picture is really powerful. The color purple means you've got a healthy heart. The color yellow and red means you have a diseased heart. And what we see is by the more amount of alcohol people drink, the more diseased heart that it becomes. The second thing this was just a few months ago, a fantastic randomized control trials performed by a group in Adelaide who took patients who were moderate alcohol drinkers. And they randomized those patients, half of them who completely stopped drinking alcohol, and half of them who continued drinking alcohol as they were. And they looked at the recurrence rates of atrial fibrillation. So this is a randomized control trial. And I tell patients this when they're in outpatient clinic, for those who are drinking excessively, that if you can significantly reduce or stop the amount of alcohol you're drinking, you can significantly reduce the amount of atrial fibrillation that you're getting in follow-up. So I think these two pictures are really powerful data that doing things yourself, independent of ablation, independent of drugs, can make a big deal. Sleep apnea. Now, sleep apnea is a recognized cause of fibrillation. Why? Because sleep apnea causes hypoxia. Sleep apnea changes the intrathoracic pressure within the thorax and indirectly changes the pressure within the atrium. It also causes a surge of sympathetic activation, which can result in vasoconstriction and increased afterload, which can backtrack on your left atrium, causing stretch, fibrosis, and fibrillation. And here's a couple more pretty pictures. So here you're seeing a patient, a control patient, who's got a lot of purple color. Remember, purple means healthy. And here you're seeing a sleep apnea patient who's got a lot of the bad colors, red, and yellow, and green. What we're saying is that in patients with sleep apnea, this can indirectly cause problems within the left atrium that can trigger fibrillation. And this was a lovely study done in 2013. It was an observational study where they took 62 patients who'd had AF ablation. And all of these patients had sleep apnea. Half of them were given CPAP. Half of them did not have their CPAP and followed up for 12 months. And what they found was the AF recurrence rate following pulmonary vein isolation in the CPAP non-user was similar to those patients who didn't even have AF ablation. That's massive. So when you're taking patients on who are overweight, who tell you that they snore, who have symptoms suggestive of sleep apnea, and you offer them catheter ablation, if they're not treated adequately for their sleep apnea, the effectiveness of this is questionable. Remember, this is not randomized data, so we cannot say that this is robust, but it certainly does give a signal that we need to be addressing the other lifestyle issues before we rush towards catheter ablation. Obesity. Now, we all know the negative impact of obesity, and that the group in Adelaide again did a fantastic observational study where they took patients, 355 patients who had a BMI greater than 27. So they were in the overweight category. And before going ahead with catheter ablation, they actually did a very nice lifestyle intervention. They offered them all a weight management program. Now, some of them adopted it, some of them didn't. And those of them who adopted it, they put them in group 1. Those of them who adopted it were able to lose about 10% of their body mass index. And all of those who failed to do that, they put them in group 2. And look at this Kaplan-Meier curve. So what this is on the right is time. On the x-axis is time. What it is on the y-axis, ablation-free period, is the freedom from atrial fibrillation with just this intervention. Now, the red line represents those patients who lost more than 10% of their body weight. So those who lost more than 10% of their body weight had a significant reduction in their AF burden without additional therapies. And that gives you robust data to support the value of weight loss. Now, in the UK, this is particularly pertinent because only last year, NHS England have released a series of commissioning restrictions for AF ablation. Usually, the EP doctor has been somewhat liberal in its use, but they have curtailed that. Now, whilst this hasn't become fully established just yet, it will do very soon. And they've said, number 1, AF ablation will not be allowed for patients with a BMI more than 40. Patients with a BMI of 35 to 40 need to demonstrate a documented weight loss of at least 10% of their body weight before they're offered AF ablation. So that's a big, big change. And it's something to be mindful for when we're considering referring someone for AF ablation. So I initially painted a very rosy picture. I showed you fantastic data about how effective it can be and said, should we be doing this for our Mr. Smith? Well, there are no doubt patients where we need to be more cautious. The groups where we need to be more cautious are those where they have no symptoms at all. Because when you're offering something for someone who has absolutely no symptoms, the only reason you're doing it is for prognosis. And as it currently stands, we have no prognostic data that AF ablation reduces mortality and the other harder impact, harder outcomes like that. When we've got very long-standing atrial fibrillation, we need to be cautious. And already NHS England have said that for those who've got long-standing persistent atrial fibrillation more than 2 years, we will no longer be able to commission that through the NHS. If you've got a BMI greater than 35, if you've got untreated sleep apnea, alcohol excess, when the left atrium is very dilated, and we normally quote around 55 millimeters or 80 millimeters. And again, NHS England have said that if you have that sort of parameter, they will not commission it. And the last one is we often try, before we consider ablation, we try and attempt an amiodarone facilitated cardioversion. Now, if that doesn't work, you really have to assume that the substrate of the atrium is really quite advanced. That AF ablation may not necessarily work. It doesn't mean with any of these it won't work. And I'm sure that there are patients who fulfill all of these criteria where it has worked. But we just need to be mindful. And so as a general approach, we need to be cautious and really considered before we rush into catheter ablation in patients meeting these particular features. In these cohort, you might be thinking, in addition to all the lifestyle interventions, antiarrhythmic medications, and sometimes we resort to putting in a pacemaker and ablating the AV node instead. Okay, so let's think about Mr. Smith. Let's apply what we've learned to him. So remember, you've now seen Mr. Smith and you are thinking about whether he should be seen by me in a clinic. Let's say he gets sent to me. What are the things that I'm thinking of now when I see Mr. Smith? So I'm going to tease out more data. And ultimately, I need to tease out whether or not the likelihood of success in offering Mr. Smith AF ablation outweighs the potential risk of complication in his procedure. So let's look at him. So he's 65. Okay, so that's pretty good. We can do AF ablation. There's no real age limit, but we are more mindful in the kind of octogenarian population. What's his symptom burden? Well, he's clearly very symptomatic. He's getting frequent palpitations. He's had a hospital admission. So it's someone where we definitely want to do something to help him. He's had symptoms for about a year. That's important because if it's long-standing atrial fibrillation, the likelihood of success becomes lesser and less, particularly as they become persistent, but he's not, he's paroxysmal. And we know that in paroxysmal patients, AF ablation is more effective. What pills has he tried? He's tried bisoprolol and flecainide. Okay, so he's tried all those and it's still not working. So yeah, okay, so he really probably could do with AF ablation. So far, that sounds like someone I'd be interested in offering catheter ablation. But what are the other things that he should be doing? Are there any of those things that need to be optimized? He's anticoagulated. There are no bleeding issues. That's all good. So I ask him in clinic, how much alcohol are you drinking? Minimal. Good. What's his BMI? In the COVID era, where we can't see patients, this becomes very difficult. So I'm actually asking all my patients when I speak to them on the phone, what is your height? What is your weight? And I go onto the BMI calculator on the NHS and I calculate their BMI. And if it's very high, maybe we shouldn't be rushing into catheter ablation so soon, because at that point, the likelihood of success goes down, the likelihood of complication goes up. And sleep apnea. I briefly screen for the symptoms of sleep apnea to determine whether or not he has any of those. And then I go through the investigations that have been sent. Is AF documented? That should be provided. Does he have any evidence of conduction tissue disease? Because at that point, you're a bit more cautious about giving antiarrhythmics. And also you're starting to think about pace and ablate if there is some advanced conduction disease. You must tell us what the echo says. What is the LV function? But in particular, what is the left atrial dimension? What is the left atrial size? Because we know as soon as the left atrium becomes very severe, the likelihood of success with catheter ablation goes right down. So I hope that exercise has explained some of the thought processes that we use in outpatient clinic to help make decisions about whether or not to offer people catheter ablation. And so next time when you see patients in general cardiology clinic and you think they need to be referred to EP, just remember this little picture, or remember this case. You can take a photo of this if you want, and just say, have I got all of this data, and include it in your referral letter, because that really is very comprehensive and really helps us make an early decision about where we're going in that particular patient's management. I'm briefly going to touch on case 2 because this offers a slightly different indication. So here we have a 55-year-old lady called Mrs. Jones. She's got a BMI which is satisfactory, doesn't drink alcohol, doesn't have sleep apnea. Perfect. Already sounds like an appropriate substrate. So she's had progressively worsening breathlessness and tiredness for the last 2 months. So those are very different symptoms. Those are not your classic AF symptoms, your classic palpitations, etc. These are very non-specific: breathlessness, tiredness. And one of the things when it comes to AF is remember that the symptoms can often be non-specific, and you have to tease out which of those symptoms are AF related and which are not. So she goes to a GP, finds a heart rate of 110, has an ECG which confirms atrial fibrillation. This is a new diagnosis, and the GP gives her some anticoagulation and a rate control. Does a Holter monitor, which comes back very quickly, which shows a persistent heart rate of 105 beats per minute. And because she's breathless and unwell, he actually organizes a BNP and an echo. BNP's right up, organizes an echo, which shows globally impaired LV function and a moderately dilated left atrium. And so the kind of working diagnosis right now could be atrial fibrillation related tachycardia. So the patient undergoes a cardioversion that gets her back to normal for 1 week. And in that period, she feels fantastic. And that's a really important therapeutic test. And I say that because remember, with persistent AF, it's very difficult to know, are the symptoms of persistent AF, the very non-specific symptoms, are they related to AF or are they just something else, deconditioning, whatnot? And now NHS England has said that for persistent patients, the symptoms must have been improved by a cardioversion, and there must be a clear temporal link between recurrence of symptoms and return of atrial fibrillation before you embark on atrial fibrillation ablation. Now, in Mrs. Jones' case, she has a recurrence thereafter, and so she's referred to an EP specialist. Now, for me, she's someone who's very appropriate to consider catheter ablation, and that's partly based on the data from this particular trial called the Castle AF trial. So this was a study of catheter ablation of atrial fibrillation in the heart failure population. And this was a randomized controlled trial. And here, this was powered to assess whether AF ablation would lower morbidity and mortality as compared to medical therapy in patients with atrial fibrillation and heart failure. So here they had a cohort of 360 patients who had an ejection fraction of less than 35% and an ICD, and had symptomatic paroxysmal or persistent symptoms that were unresponsive to medical therapy. And here you can see again in the Kaplan-Meier curve, this Kaplan-Meier curve presents data related to hard outcomes of death and hospitalization. And it demonstrated that catheter ablation was superior to medical therapy in the probability of survival to those particular endpoints. Now that's huge. And that has caused very valuable data to the EP community when it comes to referral for atrial fibrillation. But again, with everything, we must be mindful because we know that in this particular trial, it showed no benefit in those patients with an EF of less than 25%. And patients greater than 75 years old were not included in the trial. So every single time you see a patient like this, you have to consider it on a case-by-case scenario. And for me, where I feel that this data is very helpful is specifically in those patients with AF and tachycardia, where if you've seen patients whose LV function has deteriorated in persistent atrial fibrillation, those are the ones where you would be considering strongly about the value of catheter ablation in them as a means of achieving these hard endpoints in addition to symptomatic improvement. Okay. So after singing so many praises about AF ablation, after mentioning that we need to be mindful in it, the one thing that EP doctors get repeatedly mocked and frustrated by is the fact that there are recurrences, and everyone says, why are you doing all this AF ablation? It never works. So I'm going to hit this head on and try to address why we see recurrences after AF ablation. The first thing to say is that AF ablation is not a cure of AF. AF ablation is not a cure for AF. When we refer patients for AV and RT ablation, for pathway ablation, for ventricular ectopy ablation, we go into it believing that we're going to cure them of that particular arrhythmia. When we go into an AF ablation, we do not go into curing them of atrial fibrillation. The aim is to reduce the burden of atrial fibrillation and manage their symptoms. How can we cure atrial fibrillation? We know that pulmonary vein ectopy can trigger fibrillation in many patients, but not all of them. There are extra pulmonary vein triggers. And then we know that with time, with things like obesity, sleep apnea, alcohol, and just age, blood pressure, those can change the substrate within the atrium, making management of ablation far more complex than ablation can simply do on its own. We tell patients in clinic that when you're going for an AF ablation, we can't necessarily cure them, and that many patients will need more than one procedure, a course of procedures. If you read clinic letters from electrophysiologists, they usually have that as a kind of standard thing that we tell patients. Now, success rates, you'll normally say that for paroxysmal AF, it's around about 75%, and for persistent atrial fibrillation, it's around about 60%. So what are these reasons for recurrences? The first recurrence I just want to talk about, and I think is really important for you all to know, is about the blanking period recurrence. So the blanking period recurrence is not a real recurrence in any measure. After ablation, whether you've done it delivered radiofrequency energy or cryoballoon energy or cryoballoon, you cause edema and swelling in that tissue. That edema and swelling takes time to settle down. Whilst it's settling down, we actually see that patients are proarrhythmic whilst they're in that swelling phase. And it's not uncommon to see patients who had atrial fibrillation in the weeks after their ablation to go back into fibrillation or to go into an atrial tachycardia. That is not a failure. That is not recurrence. That is just the natural biological process of having an ablation. And I really want to stress that to you because many people in the general cardiology community don't know that and assume that when you have this early recurrence, that the procedure's failed. So now that we put that away, we still see a lot of recurrence. And there are three reasons. One is called pulmonary vein reconnection, and I'm going to talk about that. The second is post-ablation atrial tachycardia. And the third is having too advanced an atrial and AF substrate. Now, again, the reason why it's important to think about recurrence and referrals is that, again, NHS England have said that no patient would be able to undergo more than one redo procedure. In exceptional circumstances, this can be considered following external organizational review. So these are potentially very big changes that will happen in the AF community in terms of our referral criteria. So PV reconnection. You saw the little cartoon I made earlier on, whereby there were dots made throughout forming a wide area circumferential ablation. Now, whilst that dot may be formed acutely, it can recover. And so whilst there might be, you burn around the tissue here, that forms edema and swelling, what can happen afterwards is that swelling and what looked like it was true transmural ablation, the tissue can recover. And when the pulmonary vein ectopy is triggered, it can then escape through this reconnection back into the left atrium and trigger fibrillation. So what we often do in a redo ablation procedure is we try and find where these electrical reconnection points are and close the gap off. That's number one. Post-ablation atrial tachycardia. Now, when you deliver catheter ablation, you create scar tissue. And that scar tissue can actually form the substrate for future reentry, but not so much fibrillation, but organized atrial tachycardias. So you may often see patients who've had an AF ablation who come back in atrial tachycardia. And for those patients, trying to rate control them is really very difficult. You can try a cardioversion, but they will often get recurrence. And so catheter ablation as an attempt to sort out the reconnection site or the source of the tachycardia is often favored. So that's reason number 2. So reconnection, a scar-related atrial tachycardia, or the third thing is that the substrate that we're dealing with is too complex. So I've talked about the success rates of paroxysmal atrial fibrillation. I want you to understand that when you deal with patients with persistent and long-standing persistent AF, they are totally different arrhythmias. Your patient with paroxysmal AF, like Mr. Smith, has a totally different substrate to the persistent, long-standing persistent AF patients. And I think that they should be thought of as 2 separate disease entities. Why? The paroxysmal patients often are younger, they've got a lower CHA2DS2-VASc score. The persistents are often older, higher CHA2DS2-VASc scores, often overweight, sleep apnea. And this big thing, you hear it all the time in AF conferences. AF begets AF. What does that mean? We know that when you actually put an atrium into atrial fibrillation, the mere presence of being in fibrillation can cause the atrium to dilate, stretch, and form more fibrosis, resulting in even more AF. So the longer you leave someone in atrial fibrillation, the more likely it is that it might be harder to get them out of fibrillation moving on. And you end up with these completely different substrates, whereby in the paroxysmal patient, everything's nice and purple. But when you get to the persistence or these more complex patients, everything becomes red and yellow and green. So no wonder it's harder to get that patient with persistent back into normal rhythm and keep them in normal rhythm, especially when we're just doing the same procedure, which is isolating the pulmonary veins. So because of that, the electrophysiological community start to do more than just isolating the pulmonary veins. We start doing what's called lines. You may have heard them doing lines. There are various different ones. There's a roof line, there are mitral lines, there are inferior lines. This basically harks back to what the Cox-Maze procedure does, which is where they try to debulk the atrium into just smaller compartments in order to reduce the substrate burden within the atrium. You can do the other thing we can try and do is work out, independent of the veins, is there anything else in the body of the atrium that is triggering fibrillation? And there's all these random terms you may have heard about, EP doctors saying cafe, rotors, GPs. From your perspective as general cardiologists, you just simply have to say that these are other things within the atrium that the EP doctors are trying to find to try and reduce the AF burden. Now, individual studies of all of these things have shown benefit. The problem is this study, the STAR-AF2 trial, which was another huge study, showed that no matter what type of approach you do to AF ablation, whether you do all these other more complex ablation approaches, if you just do pulmonary vein isolation on its own, there's really no difference. So with that, a lot of AF doctors are just making sure that the pulmonary vein isolation is robust rather than trying to do so much more. So to finish, I just want to touch on complications. Now, on the right, there are a series of complications that we would normally quote in terms of consent. But I just want to talk about 3 of them: tamponade, phrenic nerve palsy, and atrioesophageal fistula. Because I think these 3, there are bits of it that as a general cardiologist, you may not be so familiar with some of the thought processes and decision-making. So tamponade is obvious. I know you all know about that. But imagine a scenario where you've got a lady whose CHA2DS2-VASc score is 3. She's had persistent atrial fibrillation. She's had an ablation, and she's in sinus rhythm at the end of the procedure. And let's say she unfortunately has tamponade. The trouble with a case like this is we as the EP doctors, you might see us quite aggressively keen to restart anticoagulation. And I just want to explain why. You know that she's CHA2DS2-VASc score 3, so she already has a higher stroke risk. She's just had a cardioversion procedure or an ablation procedure to get her from AF back to sinus rhythm. So you know the left atrial appendage is stunned. At that point, for those 30 or so days, or whatever, certainly in the first week, the risk of stroke in her is very high without anticoagulation. So we as the EP doc have to decide risk-benefit. Do you re-anticoagulate her and risk further bleed? Or do you hold off the anticoagulation, protect the bleed from within the pericardium, but increase her risk of stroke? And there is no right or wrong answer. And every clinician is different, and it's all based on a case-by-case scenario. But that clinical conundrum is really important for the general cardiology community to be aware of, because it does cause lots of difficulty in our minds. The second one briefly is just talk about phrenic nerve palsy, because many people are not aware of this in the general cardiology community. So this is a complication that happens most often related to the cryoballoon, more than with radiofrequency. The right-sided phrenic nerve runs alongside the right upper pulmonary vein. And when we are delivering cryoablation to the right upper pulmonary vein, we can inadvertently injure the right phrenic nerve. Now, we actually monitor the activity of the phrenic nerve during the procedure. But nonetheless, we can get an unfortunate complication of causing damage to the phrenic nerve. Now, reassuringly, this almost always recovers, either at the end of the case, or it usually recovers in follow-up. And the things that we do to check for this is you do afterwards an inspiratory and expiratory chest X-ray to see whether the right-sided diaphragm flattens on inspiration. Now, the last complication I want to talk about is atrioesophageal fistula. So let's just paint this picture again. A 60-year-old lady, CHA2DS2-VASc score 3, who has persistent atrial fibrillation, and she has an uncomplicated cardioversion, an uncomplicated ablation, and she's discharged the next day. Now, she represents 3 weeks later with fever, difficulty swallowing, and a seizure. In this particular patient, the diagnosis at the top of the list to be worried about, and quickly worried about, is an atrioesophageal fistula. So what is this? So this is a rare complication, but it's must-know complication because this is life-threatening. Here, what you have to understand anatomically is that the left atrium, the posterior wall, is very thin, and it sits very close to the esophagus. In fact, it's just millimeter differences. And if we deliver treatment on the left atrial posterior wall, we can cause damage to the circulation that supplies the esophagus. And the belief is that can cause necrosis of the esophagus over the forthcoming weeks. It's not a complication that happens at day 1 or day 2. We usually see this 1 to 6 weeks after the procedure. So this is a delayed complication. And what essentially happens is either material from the food pipe goes into the heart, so whether that be air, or you see content from the heart going out into the food pipe. So fever occurs because of sepsis from gut contaminants going into the body. Difficulty swallowing is because of the esophageal injury, and seizure can happen because of embolization of air or whatever going up into the brain. So this is something you have to be really mindful for. And the investigation is an urgent chest CT with contrast, not an OGD, because an OGD risks worsening. And you seek immediate senior help, whether it be the electrophysiologist and the surgeon, because this has very high mortality. So I just wanted to spend a bit of time explaining that one, because I know not everybody knows about this complication. And as an EP doctor, we are always mindful and worried about this particular one. So in summary, pulmonary vein isolation is a highly effective treatment for AFib. It's generally safe. We do a hell of a lot of it, and we're becoming really quick at doing it. I mean, to be honest, we can now do them skin to skin in about an hour, and it's becoming more and more routine. AF ablation is not a cure of AFib. The purpose is to reduce the burden of symptoms, and we consent patients from the beginning for a course of procedures. Just as valuable in this is the lifestyle interventions, weight loss, sleep apnea, blood pressure control, and alcohol reduction. And remember, persistent AF ablation efficacy is less compared to paroxysmal, and the approach to ablation in this scenario varies within the community. We don't really know what is the best approach. Thank you very much.